So good day everyone. I am BII and for today we're gonna talk about fluid therapy. So in order to understand fluid therapy, first you have to know the distribution of body water. So the average total body water of a healthy animal would approximately be 60%. However, it varies between age, sex, and nutritional status. So in younger animals, the total body water content will approximately go up to 70 to 80%, while in older animals, the total body weight would actually decrease to 50 to 55%. So almost two-thirds of the total body water is intracellular fluid, and the remaining 20% is actually the extracellular fluid, which consists of intravascular or plasma water and the vascular or the interstitial fluid. So the transcellular fluid also contains in extracellular fluid in small amounts. This includes the pleural fluid, aqueous humor, cerebral and spinal fluid, synovial fluid, um, GIT secretions. So the composition of body and therapeutic fluids consists of a set of solutes. What do we mean by solutes? It is a substance that is dissolved in a solvent. So this solvent is usually water in biological system. So the molecules of substances is called electrolytes, which they associate into charged particles called ions. So this can be positive charge, which is the cations, and negative charge, which is the anion. So in the extracellular fluid, the most abundant cations are sodium, and the most abundant anions are chloride and bicarbonate. However, in the intracellular fluid, the most major cations are actually potassium and magnesium, while the major anions is phosphate, and proteins. So the number of cations always equals the number of anions in healthy animals, which this is why therapeutic fluids are described as balanced if they resemble ECF in composition and considered unbalanced if they do not. So a variety of conditions can be effectively managed using three types of fluid. Here we have the balanced isotonic electrolytes, the hypotonic solution, and a of synthetic colloid, which we will explain later on. So, the body compartments usually separated by a semi-permeable membrane that permits the passage of water and some solutes. So, example ano is diffusion. So, diffusion actually is the passage of solutes from a higher concentration gradient to lower concentration gradient. Well, those solutes that cannot go through this space actually attracts water towards them, and this process is called osmosis. So the movement of water across cell membrane, um, the ability to attract water particles is actually called osmotic pressure. So what do we mean by osmolality? So osmolality is actually the determination of osmotic pressure of a solution basis of the relative number of particles per kilogram, while osmolarity refers to the number of particles per liter of solvent rather than per kilogram of um, solvent. So here we have osmose. Osmose is actually a compound that contributes to the osmotic pressure of a chemical solution. So the most common commercial fluid preparations would be sodium and glucose, which is salt and sugar. So tonicity is actually known as effective osmosis, which measures the ability of the combined effect of the solutes to generate an osmotic driving force causing water movement. So hypertonic, which means that the solution has increased solute and a net movement water causing a net movement that causing water to go out, therefore causing the cell to shrink, while hypotonic solution has a decreased solute concentration and a net movement of water inside the cell, so causing the cell to swell and break. So isotonic is actually the balanced solute concentration. So next we have the general principles and patient assessment. So first we have to know the patient's history and the chief complaint. So the owner should be asked questions about food and water intake. So yeah, is the animal eating? If not, when did it last eat? So is that if the animal is drinking? If so, is it increased or decreased amount? So if the animal suffering any abnormal losses such as vomiting, diarrhea, or polyuria? Um, what is the duration or how long do these abnormal losses have been? So next we have to observe the physical exam and findings. So there are three types of fluid disturbances. We have the volume, which includes the dehydration and blood loss content, such as hyperkalemia, and distribution is such as pleural effusion. So here we have evaluation and monitoring parameters that may be used. So first we have to check for its pulse rate and quality, for its capillary refill time. So in order to record the capillary refill time, you just simply have to put pressure and press the mucous membrane or gums of the animal, and if it returns less than 1 second, then the refill time is normal. However, if it is delayed, so there is a sign of dehydration. Next, we have to check for the mucous membrane color. So if it's pale, it may be a sign of anemic or anemia, while if it's a tinge of blue, then there might be a problem or poor perfusion. Next, we have to check for the respiratory rate and effort, the lung sounds, the skin turgor. So in order to check the dehydration status using the skin turgor is you have to check its rump or its neck area above the dorsal area of the neck. You have to, or its back, you have to simply pinch the skin, and if it's tenting, then there is a sign of dehydration. However, if it returns to normal position, then the animal is hydrated as long as it is not delayed. So we also have to check for the body weight. Note that the body weight of the animal is actually not because of the muscle mass, but because of the water content of the animal. So you have to also observe its mental status, weak ba siya? You have to check for its extremity temperature. So PCV, where total solids and the total protein are actually decreased during dehydration. So, however, PCV may appear to be normal in anemic patients. However, this is due only to the hemo concentration. Next, we have also to check for the serum lactate, for the urine specific gravity. So, the urine specific gravity greater than 1.030 usually indicates that the kidneys are responding to the dehydration in an appropriate manner. So if it increases more than that, then there is a problem. So we also have to check for the bond, creatinine, electrolytes, blood pressure, venous or arterial blood gases, and oxygen saturation. So here, as you can see in the picture, we have here in the lower left a dog that has a blue tongue. So there are actually breeds that have a natural blue tongue features. So that is the importance of signalment and knowing the history of the patient if it's normal or abnormal. So here we also have to in the right upper left. I'm sorry, in the right up, upper right you can see that the dog is actually showing signs of ventricuflexion. Therefore, there is a weak sign of weakness. So in the upper left, you can see that the cat is actually opening the mouth of the cat using the mandibles, lower mandibles. So you have to check the heart rate. And here in the lower right, you can see that the vet is actually checking for the color of the mucous membrane using the gums of the animal. So after that, after physical examinations, we have to identify the route of administration. So we can use oral administration if the GIT is functional and no contraindications exist, so there is no vomiting. So however, if there is this anticipated dehydration or mild fluid volume disturbance in an outpatient setting, we can use subcutaneous. So you can actually also use subcutaneous in the absence of vasoconstriction and hypovolemia. The rate of absorption is approximately 6 to 8 hours, and only isotonic fluids should be administered by this route. Do not use dextrose, hypertonic, or hypotonic solution because there is possibility of necrosis and infections. So subcutaneous fluids are best used to prevent losses and are not adequate for replacement therapy in any other or anything other than very mild dehydration. Next, we have to use IV or intraosseous in hospitalized patients not eating or drinking normally. They are anesthetized, means a rapid and large volume of fluid administration. So intraosseous, however, administered in the bone marrow and best used for short-term administration of fluids or drugs. In critical care setting, it is used in patients with a need for rapid and large volume fluid administration, administration of hypertonic fluids, and or monitoring central venous pressure. So we can actually use central IV. So there is no contraindications related to the use of type of fluids to be used in um, IV. So here we have to determine the types of fluid to be used. We actually have two types, the crystalloid fluids and the colloid fluids. So crystalloid fluids, we have free water, which is 5% dextrose in sterile water, or 0.45 saline. So this hypotonic solution replenishes the interstitial fluid and ICF compartments. Next, we have replacement solutions. So these balanced isotonic solutions are designed to replenish the extracellular fluid compartments. So this includes increasing intravascular volume and restoring perfusion. So it is ideal to replace losses. In maintenance solution, these are also balanced isotonic solutions which have less sodium and more potassium than replacement fluids. So they are suitable for long-term fluid therapy after the restoration of intravascular volume and correction of electrolytes derangement. So they rarely used alone. They usually combine with a ratio of 0.9 sodium chloride to closely match the composition of fluid in the intravascular space, preventing unwanted fluid shifts between compartments. So in hypertonic solutions, we have 7% to 23% saline. So these fluids contain solute concentration higher than that of ICF. So therefore, since because of this oncotic pool, high, hypertonic solution should never be used in severe cases of dehydration because it will cause the cell to shrink. So next we have colloid fluids. So colloid contains large osmotically active particles that work to hold in the vasculature after administration. So colloids are actually difficult to administer. Sufficient volume of fluids rapidly enough to resuscitate a patient, and or when achieving the greatest cardiovascular benefit with the least volume of infused fluids is desirable. So we have synthetic colloids. These are fluids with large molecules designed to provide oncotic pressure to support within the intravascular space. While natural colloids, we have blood products such as whole blood, packed red blood cells, um, plasma, and albumin. So whole blood and PRBCs have the added benefit of providing oxygen carrying capacity, helping to prevent and treat hypoxia. However, the use of colloids is highly controversial in human medicine as well as in Vetmed, since the recent research implicates a link between the use of the synthetic colloid can actually cause acute kidney injury in dogs. So after we identify the fluids to use, we have to now develop a treatment plan. So fluid therapy in veterinary hospital or clinic has three primary phases which can overlap and alternate depending on how a patient presents and the progression of its disease process. So first we have the resuscitation phase. This refers to correcting shock and other life-threatening fluids deficits. So this is actually the critical phase of the fluid therapy where you need to exert balance. And after that, we have the replacement phase. This is the time taken to replace dehydration deficits and any problems, while the maintenance phase covers fluids provided during hospitalization to support and maintain homeostasis. So these are the example of disease processes that we may use. So first, we have the cardiac disease. So we can actually use low-dose maintenance crystalloids such as 0.45 saline with dextrose. So we can actually use hypotonic solutions. Next, we have the vomiting or diarrhea. We can use replacement crystalloids such as lactated Winger's solution, normosul or plasmalite A in diabetic ketoacidosis. We can also use replacement crystalloids. However, in hemorrhage, since there is loss of blood, we can actually use natriuretic colloid such as plasma, whole blood, and packed red blood cells. So, fluid therapy formulas. So, to calculate the dehydration deficit of the animals, we can multiply the body weight times percent dehydration as a decimal. So, equals the liters of fluid required to correct hydration. So, in dogs, we can multiply body weight to the power of 0.75 times 132 is equals to the 24-hour fluid requirement in milliliters. So, as a rule of thumb, the fluid should be administered 2 to 6 ml per kilogram per hour. In cats, we should multiply it to 80 equals to 24-hour fluid requirement in milliliters. So here we have to administer in small amounts 2 to 3 ml kg kilogram per hour. So if there is an ongoing losses such as diarrhea, vomiting, or polyuria, it must be calculated and added to the total maintenance requirement obtained from these formulas. So next we have patient monitoring. So because the calculation of fluid volume is based on subjective data, there is potential inaccuracies. So therefore, it is necessary to reassess the patient often. So the patient may require more or less the original calculated volume from time to time. So they should be weighed at the beginning of therapy and several times a day after to determine the fluid gains and losses. So acute changes in body weight, as I've mentioned earlier, is a result of fluid gains and losses rather than change in body mass. So a 0.5 kilogram weight gain is equivalent to 0.5 liter fluid gain. So that's all. Thank you.